Hi, this is Jason Radmaker of TBD Solutions. Thank you for watching the presentation on Prepaid Inpatient Health Plans, made especially for Mid-State Health Network.
If you have ever wondered what a Prepaid Inpatient Health Plan is, or PIHP, this presentation is for you. In it, we will be covering the definition, history, functions, and the core requirements for which a PIHP is held accountable. We'll also consider the strengths of Mid-State Health Network as the PIHP over a 21-county mid-Michigan region, and look closely at the role of CEO for both a PIHP and a Community Mental Health Service Program, or CMHSP, the similarities and the differences. Finally, we will conclude with why meaningful board member participation is absolutely vital for a healthy, functioning PIHP.
A PIHP is federally defined as one of the health plans required of the Centers for Medicare and Medicaid Services. PIHPs are different in that they work directly with state Medicaid agencies and are paid through a prepaid capitated payment. This means that they receive lump sums of Medicaid dollars for distribution for service. They are also responsible for arranging inpatient health care for people who are eligible for their services, and they do not bear the full risk of an insurance plan and instead share that risk with the state Medicaid agency. The history of public behavioral health care starts back in 1939, when the Social Welfare Act required that public funds could be used for some specialty mental health, developmental disability, and substance use disorder services. This was expanded in 1963 when President John F. Kennedy enacted the Community Mental Health Act. The Michigan State Constitution was then amended to include public health, welfare, and adequate treatment of citizens with mental and physical challenges. In 1974, the Michigan Mental Health Code was developed to require CMHSPs to provide comprehensive mental health services. The modern Michigan Specialty Supports and Service Contract found its origins in 1995 when the Center for Medicare and Medicaid Services approved the state's initial waivers to allow for local and regional management of Medicaid services. So the state of Michigan, working with the 49 community mental health service programs, asked them to take on responsibility as prepaid health plans for these Medicaid services. In 2002, these were converted into 18 prepaid inpatient health plans following an application for participation process. The AFP was repeated again in 2013, and in 2014, the 18 PIHPs were consolidated into 10. 3 of these organizations were formed under urban cooperation agreements. The remaining 7 were formed under Section 1204B of the Michigan Mental Health Code. These were to be regional entities that were jointly owned and governed by the sponsoring community mental health service programs.
In 2013, the Michigan Department of Community Health established an application for participation, or AFP, in its restructuring of the 18-member PIHP system down to 10. Within this application for participation, the state identified several core functions that would have to be fulfilled. Governance, or the ability by which the organization would be led and managed. Administrative functions, the needs for finance, quality, utilization management, information technology, and others. Accreditation, the process of review that healthcare organizations participate in to demonstrate their ability to meet the standards of a professional accrediting agency. External quality review, the need for the PIHP to conduct quality reviews of its member network as well as the state's review through its external quality review organization. And finally, listing several public policy initiatives that the PIHP would be responsible for. It is important to note that a PIHP does not function as an insurance company does in that it doesn't bear the full risk of the cost of services. This means that in the event that there was much greater need than there was resource, the state of Michigan shares the risk with the PIHP. Also, funding for a PIHP differs from that of a traditional insurance company in that it receives its funding based on a number of persons who are eligible for Medicaid every month. This per eligible per month, or PEPM, is the basis by which the funding is calculated and sent monthly rather than as a reimbursement from the state for fee-for-service arrangements. These core functions are allowed to be carried out in one of three ways. They can be retained, delegated, or contracted. A retained function is a function of the PIHP that is housed within the PIHP organization. This is considered a centralized function. A delegated function is one in which the provider network agrees to perform the function on behalf of the Prepaid Inpatient Health Plan. It is important to note that under the Specialty Supports and Services contract, the Michigan Department of Health and Human Services expects the PIHP to retain its role in monitoring and oversight of these delegated functions. The final way in which a function may be fulfilled is via a contract with a single entity. This can include either a CMHSP participant within the region or a private external third party. The only function that the Department of Community Health said could not be delegated was that of information technology. This expectation continues in the Specialty Supports and Services contract by the Michigan Department of Health and Human Services. Under the 2013 AFP, applicants were allowed to form prepaid inpatient health plans under one of two governance models: the Urban Cooperation Act and regional entities. The Urban Cooperation Act was designed for large community mental health agencies, organizations, and authorities to form as single county entities. The state of Michigan only allowed the three largest counties to participate under the UCA, those of Oakland, Macomb, and Wayne County. All other counties were required to form together as regional entities in sponsoring a PIHP. This was allowed under Section 1204B of the Michigan Mental Health Code. Under this governance model, the PIHP is fully owned by the community mental health service programs within its region. Midstate Health Network is one of these regional entities. There are 7 in the state, all located outside of the southeastern Michigan metro region. The state of Michigan's 2013 AFP required a number of executive leadership positions and other core executive staff for the fulfillment of the PIHP functions. These included a chief executive officer, chief operating officer, chief financial officer, and chief information officer. It was the stated desire of the state that these key executive positions be 100% dedicated to the functions of the PIHP and, if possible, be employees of the PIHP directly, though allowing for leased or other contracted positions was permissible, with the sole exception of the Chief Executive Officer position, which would be 100% employed by the Board of Directors. The other positions that were required of a PIHP included that of Medical Director, Substance Use Disorder Prevention and Treatment Director, a Human Resources Director, and Compliance Officer, or person responsible for overall program integrity. These other executive staff positions were not required to be direct employees of the PIHP. So although they could be leased or contracted, the state of Michigan did see them as very important functions for the successful completion of PIHP responsibilities. Of the administrative functions of the PIHP, financial management is one of the most important. In addition to providing the type of fiduciary responsibility of oversight and monitoring, it is the key function to ensure that CMH programs and services are funded. The Chief Financial Officer is responsible for ensuring that revenue analysis is performed and that by the projections of available resources that budgeting for both the PIHP and CMHSPs occurs. It is responsible for cost analysis and rate setting, as well as providing the type of analysis and risk modeling that ensures that the insurance and risk pools are fully covered. While delegated, it is responsible ultimately for claims adjudication and payment and the ongoing audits that must occur to ensure the financial viability of the organization and its members, CMHSPs. Of the administrative functions of a PIHP, Information Systems Management is unique. First, it is the only administrative function that the state of Michigan required in their 2013 AFP to not be delegated to the provider network. Information Systems Management carries a heavy load as almost all information is conducted using technology. All financial and care information is almost fully electronic. It's the backbone for receiving financial data from the state, distributing funds to the CMHSPs for service, demonstrating quality and compliance to the state, while CMHSP IT systems are vital to collect information, and the State of Michigan Data Warehouse is needed to be able to send information. It's the PIHP that acts as the conduit and single point of consolidation for this information. Ultimately, it is also that information by which the performance of the entire region is judged. The PIHP also is heavily leveraged in population health management using complex data analytics for both the CMHSP participants and the PIHP to analyze overall indicators of population health and cross-longitudinal care that bridges primary care and behavioral health care funded by Medicaid. Continuing with administrative functions that can be delegated, Provider Network Management is a function that encompasses activities directed at ensuring that qualified providers in sufficient number and variety are available to permit meaningful consumer choice, and that the provider network is in compliance with regulatory requirements and the performance expectations of the PIHP. Key elements of provider network management include provider contract management and oversight, development of procurement approaches and policies that cover the entire provider network, and ensuring that only qualified professionals are providing services to individuals served by the community mental health service programs and their agencies. This includes performing background checks on qualifications and confirming with primary sources the credentials of professional staff, such as psychiatrists, social workers, and doctors. Utilization management is another PIHP function that has administrative requirements pertaining to the assurance of appropriate clinical service delivery. Utilization management borrows from an insurance term, eligible beneficiaries. Eligible beneficiaries are people who qualify for Medicaid coverage and are also in need of service. Utilization management is designed to ensure that only eligible beneficiaries receive the benefits of the plan, and that they receive all of the medical necessary treatment plan benefits required to meet their needs. So it ensures that the correct intensity, scope, and duration of services is provided. Finally, utilization management also ensures that beneficiaries are linked to other Medicaid, health plan, or services as necessary. The core components of utilization management include access and eligibility determination, utilization management protocols and approaches, authorizations, and utilization review. The customer services function encompasses activities directed at the entire population of the region's service area, including all services and supports to consumers as provided locally through CMHSPs. Customer services include general orientation to services, a consumer handbook with regional consistency and local information, and the operation of a phone line or website to provide information about plan benefits and responses to general inquiries. Both formal and informal grievance and appeal mechanisms are coordinated as part of the customer services function. Community benefit is also provided and includes collaborative activities, activities designed to promote wellness and healthy communities, and coordinated human service delivery systems of care. Oversight and monitoring is a key phrase used frequently at a PIHP. With the possible exception of utilization management, no other administrative function encompasses the traits of oversight and monitoring as that of the quality management function.
Effective quality management encompasses activities directed at ensuring that standards for staff, programs, and management performance exist. It ensures that CMHSP compliance is assessed and that ongoing improvements are introduced, monitored, and assessed with respect to their outcomes. Key activities include identification and participation in mandatory regional performance improvement programs, collaborative development of regional quality standards, education on quality processes, compliance areas, and approaches to continuous quality improvement. This administrative function ensures high quality through its monitoring of performance assessments and by performing on-site reviews with CMHSPs. Moving past the administrative functions of a PIHP, we will now take a look at several informational items. The first is accreditation. Accreditation is an external review by an impartial third-party organization to make sure that business is conducted in a way that meets national standards. Community mental health service programs are familiar with CARF or the Joint Commission as their primary accrediting bodies. For a health plan, the National Committee for Quality Assurance, or NCQA, and URAC, which was formerly known as the Utilization Review Accreditation Committee, are the most common. While the state does not require accreditation for PIHPs, there are several additional benefits that could be considered. The Balanced Budget Act of 1997 included a number of stipulations for Medicaid-covered services. Among these was the requirement for an external quality review. The state of Michigan is contracted with the Health Services Advisory Group, or HSAG, to provide external quality review to validate BBA standards. This includes a validation of both performance measures and the annual performance improvement project. HSAG, acting as the state's external quality review organization, works closely with the PIHP to ensure regional compliance with these initiatives and that high-quality Medicaid services are delivered by CMHSPs throughout the region. A number of public policy initiatives were required of the PIHP. These include crisis response capacity, which means ongoing tracking and trending of critical incidents and sentinel events, the employment of strategies to prevent critical incidents and sentinel events, and having in place the capacity to regionally respond to behavioral or medical crises. It also includes health and welfare initiatives that focus on the overall health of the population. Compliance with Olmstead, which is a Title II integration mandate of the Americans with Disability Act that requires services, programs, and activities of a public entity must be provided in the most integrated setting possible. Substance use disorder prevention and treatment, and a recovery-oriented approach for the provider network, so that the mission and vision support the dimensions and principles of recovery. While service delivery is the primary domain of community mental health service programs, the PIHP does have a responsibility for oversight and monitoring of regional services. These include the list of services provided here for outpatient, outreach and residential, and inpatient services. A key role of the Prepaid Inpatient Health Plan is as a coordinator of funding for services within the region. Medicaid services are provided from the state of Michigan for individuals with mental illness, children with severe emotional disabilities, and individuals requiring supports and services that have intellectual or developmental disabilities. For persons with substance use disorders, block grant funding makes up the majority of the funding for service. The Medicaid rates are developed by private actuaries that the state of Michigan contracts with, who analyze the risks inherent to the population that is served. The Michigan Department of Health and Human Services then determines the rate within a given range that the PIHP will receive. Mid-State Health Network's success as a premier PIHP can be traced to the leadership of its board and CEOs in its formation by the community mental health service programs, each of whom shared the values of excellence, regional collaboration, and local control. The region has had considerable success through active engagement of the Michigan Department of Health and Human Services and the local engagement of legislators and county officials within their communities. A hallmark of Mid-State Health Network has been the collaborative relationships of its CEOs in the Operations Council. This collaborative spirit has permeated the successful engagement of efforts by other councils and committees in the region. The development of Mid-State Health Network staff has helped assure adequate resources for centralized efforts, and the PIHP has benefited from its approach to fulfill all contractual and legal obligations of the Prepaid Inpatient Health Plan. Board members of the regional entities that make up 7 of the state's 10 PIHPs have a very tough job. They're essentially asked to wear 2 different hats, one when they are a member of their local Community Mental Health Service Program Board, and another when they're addressing the regional requirements of a PIHP. As a CMH board member, local service provision, program development, and resourcing are of the utmost importance. The local board member assures engagement of their community partners, family members, and the persons that are served by their CMH. It is where the majority of clinical expertise is required. But when switching to the PIHP hat, the board member now focuses on regional initiatives, such as the fulfillment of the Medicaid Specialty Supports and Services contract with the Michigan Department of Health and Human Services. They also ensure regional compliance, quality and consistency, and the allocation of Medicaid resources. Ultimately, the PIHP is charged with oversight and monitoring, for which board members ensure responsibility. It's a tough job to avoid conflicts of interest in engaging regional initiatives while being fully informed Community Mental Health Service Program board members. But done well, it can be an excellent model where each hat helps inform the other without crossing the responsibilities of both. The Chief Executive Officer role for the PIHP and the CMH are both intrinsically intertwined and completely separate. Both require leaders who can see the big picture and also dig into great levels of detail. Many of the leadership qualities are the same: integrity, transparency, effective communication, and a strong vision. And the oversight of administrative functions such as finance, IT, and quality are very similar. But the differences are also significant. The PIHP CEO focuses less on program development and service delivery than it does on creating systems of compliance, oversight, and monitoring. The regional approach to administrative functions requires a broader perspective to protect collaboration among the 12 CMHSPs to achieve the balance of both local control and regional consistency. Working with their board, the PIHP CEO must ensure the coordination of state-level initiatives and the regional requirements to meet BBA compliance initiatives. While the PIHP and CMHSP CEO are different, they must work well together to achieve excellent care for the persons served by the region. Thank you for watching our presentation on prepaid inpatient health plans made especially for Mid-State Health Network. This has been Jason Radmaker of TBD Solutions. If you have any follow-up questions, you can contact us via email at info@tbdsolutions.com or via our nationwide toll-free phone number 877-823-7348.